So we are having a question about possible complications due to the tumor lysis, like hypotassium or the renal dysfunction. Or
Yeah, I can
do you
maybe
have?
well, maybe before I
Yes,
can give
please, Joe.
yeah, I can maybe give a global perspective on it, but before I do, maybe Koji and Albert, although we talk quite a bit, maybe you guys have you experienced that on in your cases? Do you want to speak to it first, and then I can give kind of what just having worked closely with a lot of the centers, I can give a sense of where we are as a company and what we've seen.
Yeah,
Well,
I mean, oh, go ahead. Yeah.
please do, please do.
Okay. Yeah, I'll make it short because, I have never actually experienced any renal issues among our patient population at this point, but I'm hearing it's mainly for neuroendocrine tumor. We don't have a lot of neuroendocrine tumor indication here, so maybe that's why.
Albert, on
Yeah,
your end?
we've treated about 50 to 60 patients by now, and I don't think, I mean, initially we concerned about whether it would be like ablation, whether there would be hyperkalemia, renal impairment. But in fact, we didn't see any hyperkalemia or renal impairment. I think partly because the treatment is, in fact, it's not thermal. So that's actually very different from ablation, even though it's ablative effect, but it's not a thermal ablation. So that's why, I mean, we didn't see that hyperkalemia or renal impairment in our patients so far.
Yeah, so I can speak to globally, as Koji outlined, where we first saw acute kidney injury or again evidence of acute renal failure was first in the neuroendocrine setting, where one of the physicians was very interested in using histotripsy as a way to essentially debulk disease, similar to what you do for surgery for where you have multifocal neuroendocrine. So, and in a couple of days, within a couple of days, treated 3 patients pretty aggressively, and all 3 patients did get sort of a bit of an elevation in creatinine, and a few of them needed intervention, especially with fluids, and one required acute dialysis. Happy to report that all 3 of them have completely recovered from that, and mechanistically, although we're still learning, we think that it's related to that, as you know, neuroendocrine tumors tend to be, somewhat viable, much more, higher levels of protein as opposed to other tumors like colorectal or pancreas, where they're very necrotic and hypoxic. So we think there's just a very rapid release of proteins that can overload the kidney. And since then, a number of physicians have placed Foleys during histotripsy treatment when they intend to treat large volumes of tumor, either within one tumor or multifocal tumors. And what they've tended to do is if they start seeing any, darker urine or hematuria, that they tend to then kind of pause and tend to stop. And as long as they've stopped at that moment, they haven't seen any sort of sequelae from it, that they even sort of tend to avoid even any rise in creatinine. And then they'll essentially come back and retreat the patient, next time. I will say there's been a few others outside of neuroendocrine where most of these have been reported to the FDA as part of an MDR. But there's a few that with other cancers where it appears to be more related to underlying kidney status, their current condition. And a number of those patients already had kind of underlying comorbidities, whether it be hypertension, diabetes, or other things. So one thing I'll just mention is we have a monthly peer-to-peer meeting where we open it up to all of our users globally. And in that meeting, we just are essentially provided an opportunity space for the different physicians to share best practices. And that's where this first came up, and it was discussed openly. And so what we educate our physicians is just to be aware that if they're going to treat large volumes, to just, again, make sure that you know what the current kidney condition, renal function is of that patient, and again, consider putting a Foley. And I think with those precautions, as well as, hydration, being a little bit careful if you're going to use post contrast and, CT contrast, which obviously can also be contributing, et cetera. And so with that information, we are seeing, very little recurrence of this. And it's something that, again, we just look at it as a feedback loop, as we learn things from the physicians, we try to get it back to the users very rapidly. so that we can make sure that we treat this, treat as safely as possible with the best outcomes.
Thank you. So, yep. Now another question. So, Koji and Albert, have you ever used histotripsy for the metastasis from breast cancer?
Yeah, well, to my surprise, once we started this clinical trial, we had a lot of inquiries from breast cancer, liver metastasis, and we did treat some of these patients. But I think what you ask about whether histotripsy is better for HCC and colorectal liver mets, perhaps I can make a comment on that as well. I think first of all, in Asia, I think we have a lot more HCC, and so far, I don't see a lot of in terms of the ablative effect. Both HCC and colorectal liver metastasis, we were able to achieve quite similar results. But in fact, HCC, what I see histotripsy is actually a multimodality treatment. So we use the histotripsy to treat a multifocal small tumors. And sometimes we can, after the treatment, we add immunotherapy as well, because some of our patients with immunotherapy afterwards, they do have a very remarkable effect. So I think this is something I want to look into in the future. But so far, my experience so far, it's multifocal small tumors, especially those with oligoprogression in one or two predominant nodules. I think this is where they have the biggest effect in terms of the histotripsy. For breast cancer patient, yes, we do have a lot of referrals, but a lot of time they have multiple sites of metastasis. So we have treated one or two patients with good effect. But then, I'm still exploring the position of histotripsy in relation to the other treatment that the patient is receiving, because most of the time they're heavily chemoed or target agents or various sorts of things. So I'm still exploring the role in breast cancer patients.
Yeah, I completely agree with your comment. And we had the same situation, even when we get a referral, it's usually a multifocal breast cancer mets. And, we kind of start thinking about what's the role of histotripsy. And again, one of the unique situation we had was, it was actually from a surgical oncologist who tried to do a liver resection. And then he works with me closely, and he knew this technology. And the tumor was right next to the middle hepatic vein. And he asked me to actually treat to get a margin. We tried to do it, and then the patient actually developed intrahepatic mets. And then, we are doing immunotherapy so that we can get a control. So I think that's really a kind of a challenge for the breast cancer. I completely agree with Albert's point.
Mm.
So
how about the liver mets from the, sorry. Andrew,
Go ahead.
Please.
Well,
No.
sorry. Just, one thing I was thinking, one Achilles heel of this technology when compared to ablations, perhaps, is that at the end of the day, you still need to stick a needle into many of these tumors to get a diagnosis. So you can't avoid it necessarily. But we have radiomics now, right? We have AI, which can give us more and more precise diagnoses. So is the paradigm going to completely change one day, perhaps, where we're not even going to need to do biopsies? We're just going to be able to use radiomics, get the diagnosis, and then treat. I mean, this is why I'm going to go back to you, Albert. I'm still nervous as a HPB surgeon. I'm still nervous if I can't get my hands on this device.
It really depends where you practice. I think in terms of diagnostic dilemma for HCC is actually not so much in Asia, because to start with, a lot of our patients, they're Hep B carrier, Hep C carrier, high alpha fetoprotein, typical imaging changes on the scan. Normally, we don't need to take a biopsy for these kind of tumors. So for us, that would be a more straightforward. However, I agree with you for colorectal liver mets, sometimes you might want to get a biopsy to do genotyping or immunohistochemical staining. That might be a little bit different. But as I said, my research is mainly on HCC, and I find this is actually this technology. I think there is a benefit for that, because after all, I don't think it's not kind of a contradictory. It's not, you have histotripsy, then you don't do ablation or you don't do TACE. It's not like that. And in fact, what we should look at is, out of all the tools that we have, now we have one additional tools that can help our patients. So in the future, they can have different sorts of treatments. It's a multimodality treatment. So the concept of multimodality, that is the most important thing that we should embark on. It's not that now with histotripsy, then we don't do microwave ablation. It's not like that, because there's some locations, I can tell you that ablation may be more favorable, but there are deep-seated locations that I find histotripsy particularly useful, because those locations sometimes it's quite difficult to put the needle in. And there are actually some limitations where histotripsy cannot perform as well. And we can talk about that later. So I do believe as a
please
role.
tell us. Someone asked a question. Please explain what you think ablation might be beneficial.
So for example, I think histotripsy is particularly useful in deep-seated, like segment 5, segment 6, right in the middle of the segment 5 or segment 4, or in the left lobe, deep-seated tumors, histotripsy, it's wonderful. In segment 8, it really depends on the body configuration as well. So now big segment tumors as well. But sometimes the rib cage conceal the tumors. You need to collapse the lung very well. So there's a lot of factors that can change the treatment effect. So quite, I mean, fortunately in Hong Kong, the patients, they're quite slim. They're not big size. And even though the liver is hidden behind the rib cage, segment 8, we can do an intercostal approach and collapse the lung, and we can see that quite clearly. But it's not always possible. For example, in the segment 7, if it's too posterior, it might be quite difficult as well. So there are actually sometimes the tumor location that prohibit histotripsy. And in those situations, then you might have to go for ablation, whether it's a laparoscopic or percutaneous ablation, to deal with those situations. So as I said, it's complementary. So as a surgeon, I see the role that now I can choose the best treatment for my patient, whether histo, a lab wedge surgery, or ablation. Basically it's a full paradigm, I would say.
You're like my therapist. So you make me feel better and better the more you talk.
I think this is a very important point, and we probably have to, I don't know if we need a consensus meeting or whatever, but one of the dynamics we have here in our center is, we discuss these tumor treatment option in a tumor board. To answer Andrew's question, it's usually a radiation oncologist and IR guys who feel like, they're threatened by this technology because, it's unknown technology, which sounds fancy. Maybe we can destroy anything, but they start understanding the limitation of histotripsy. And now we kind of know when to apply ablation, when we apply SBRT. So there must be some kind of a guideline we can develop, just drawing the border of where we can utilize histotripsy, and eventually if we can put this technology on those guidelines like a BCLC or whatever, I think that's when we can say this technology is accepted as a standard of care. So maybe that I don't know. I'm not in a position to say this, but Joe, I think that's probably the goal for you guys to get into the guideline, I guess.
Well, I think, to add, I think you both stated it very well. And again, admittedly, we're a little over a year into therapy, right? So acknowledging that we're still learning, we're still following patients, et cetera. But I think to your point, this is a technology that is really optimally, presented in a tumor board. In fact, we are going to ASCO this year. We're meeting with medical oncologists. We recognize that a lot of them don't have an understanding of histotripsy. We think that, we've been to a lot of meetings and have had lots of discussions with hepatobiliary surgeons, radiation oncologists, interventional radiologists, but we also have a responsibility to educate medical oncologists. One of the things that we didn't mention is that I think, or maybe we touched on it, but because of the low complication rate and how well it's tolerated, patients typically go home the same day or the next day, and maybe that's something we could talk a little bit about too. And so that affords them the ability to go right back on systemic therapy. I've heard reports of some physicians treating patients while they're on their hepatic arterial infusion pump, like literally getting therapy. Not saying we advocate for that, but just acknowledging that given the complication rate being so low, that we're seeing medical oncologists are very comfortable integrating this therapy. And I think when you think about the oligometastatic paradigm, especially the oligoprogressive paradigm, of being able to treat a few tumors and keeping them on their therapy as opposed to shifting to another line of therapy. So I think as you think about the treatment trajectory, we're excited about where this can fit in across multiple tumor types and really bringing in medical oncology to help us understand where we can integrate it and then also where we can combine it optimally with therapies moving forward. I'd like to touch on, back to your point, Koji, I think that's the goal of the Boombox trial to some capacity. And the goal of that trial really is to collect data across all these different tumor types across their trajectory and try to really understand where we have the best opportunities to help patients and maybe where we don't. As you guys mentioned, there's some areas right now where we're limited. I think two other quick ones is that one is we are continuing to expand the technology. We are looking to use, right now we're limited to a 4-centimeter volume. Next year, we're working towards a 5-centimeter volume, which will give even more. And again, that's even though it sounds like only a centimeter exponentially, it's quite larger. So it gives more opportunity to treat holistically and in an automatic way, right? Taking away some of the user challenges that can occur. We also have the ability to do send and receive where right now all of our piezoelectric elements come on at the same time like a light, but we'll be evolving to where different elements can come on at different times to optimize the energy at that isocenter so that we can be able to treat areas that might be a little bit more challenging today that might be blocked by rib or lung, et cetera. And then also we're looking at creating ways to deliver deeper so that where we can push the bubble cloud deeper within the body to treat patients that might have a higher, kind of BMI, et cetera. And then Andrew, the last one I'll just mention is with liquid biopsies, right? One cool thing that's been discussed is, let's say for cholangiocarcinoma, which we know is very challenging. You have to do a spyglass, biopsy. You're putting them through stents, internal, external. They get cholangitis, all those things. Imagine a future with AI where you can say, okay, on imaging, it looks like it is. We have a CA19-9, even with blockage. And can we just treat with histotripsy at diagnosis, relieve the obstruction, do a liquid biopsy, characterize it with a molecular profile, and never stent the patient and put them immediately right back on put them on systemic therapy. So you can envision a world where we can really get patients on the therapy they need more rapidly with a lot less invasive techniques.
Non-invasive surgery, it's coming.
Yeah, from the standpoint of AI surgery, I think that the stiffness, the texture of the tumor is a very important factor associated with outcomes. And I think that if the AI evaluation of the stiffness by the elastography or the MR elastography may enable the accurate prediction or the selection of the treatment between the histotripsy, local ablative therapy, or surgery. So this is the future style of the treatment
Thank
for
you,
liver tumors.
Takeaki.
And let me show you.
We actually already working on the ultrasound elastography stuff.
Oh, really?
We use ultrasound elastography to see which tumor has a good response. And also, I'm trying to use a contrast ultrasound to characterize and also differentiate dead part of the tumor versus live part of tumor. Because these patients undergo a lot of treatment. Even using one lesion, there are some necrotic part, there's a viable part. So those are things we're trying here.
Do you use the contrast material after the treatment, after the histotripsy to detect the viable part, residual part?
So, yeah, I just had a discussion with a radiology here like 2 weeks ago, and we just decided to together.
Quite a new topic.
We are waiting to do a contrast ultrasound when I do a screening ultrasound, because I don't think we can do a contrast ultrasound right before treatment, because that's gonna interfere the treatment because it's bubble versus bubble. So, but I think after treatment we can definitely see the effect with a contrast ultrasound. I try to see the effect with a CT scan or whatever the modality. It's just a mix of information and some treatment effects. So we'll see, but that's some new idea we are trying to have here.
Thank you. So any other comments from the audiences? Okay, I think it's time to close this webinar. And let me show you this slide before I forget. Oh, wait a moment. So I think I should show you this slide before the closing. just to encourage you to submit your papers to the journal AI surgery, right, Andrew? Okay.
Bravo, bravo.
And
Grazie.
I'd like to also to express my gratitude to Janet from Histotripsy and Zoe from AI surgery for making this event possible. We sincerely hope that Histotripsy will become powerful and a nearly non-invasive treatment for cancer patients around the world. Thank you again, and we hope to see you again at a future event.